Hello everyone, welcome to Dr. Shravani's Med Concepts. Today I am ready to take you through a beautiful and difficult journey of papillary neoplasms of breast, ultimately landing you to the final destination of papillary neoplasms of breast at a glance. Coming in detail about the topic, this is WHO classification 5th edition, in which epithelial tumors of the breast will have separate entity known as papillary neoplasms, which includes intraductal papilloma, papillary ductal carcinoma in situ, encapsulated papillary carcinoma, solid papillary carcinoma which can be in situ and invasive papillary carcinoma. Invasive micropapillary carcinoma is a separate entity which is not included in the papillary neoplasms, but it is a part of invasive breast carcinoma. Going in detail about the papillary neoplasms of the breast. This is flowchart showing how we should approach to a case of papillary neoplasm. Once you see epithelial proliferation forming papillae, you will confirm that it is papillary neoplasm. Next step is you should look for stromal invasion, whether stromal invasion is absent or present. If the stromal invasion is not seen, next step is you should look for a capsule. Capsule is absent or present. If the capsule is not seen, the possibilities can be intraductal papilloma, papillary ductal carcinoma in situ, or solid papillary ductal carcinoma in situ. If you are seeing capsule, it will be encapsulated papillary carcinoma. This is the classical feature. Encapsulated papillary carcinoma only will have capsule among all papillary neoplasms. Now, how we should exclude between intraductal papilloma and DCIS is presence of myoepithelial cells. This myoepithelial cells, in case of ductal papilloma, they are distributed within the papillae and also at the periphery. If it is in case of DCIS, they are present only at the periphery and absent within the papillae. So, within the papillae, the myoepithelial cells are absent in case of DCIS and distributed only at the periphery. In case of encapsulated papillary carcinoma, the myoepithelial cells are absent within the papillae as well as at the periphery. Coming to invasion. So, if you see invasion, the possibilities can be solid papillary carcinoma or invasive papillary carcinoma. So, you should look for the architecture. So, if it is solid pattern, it is solid invasive papillary carcinoma. In solid invasive papillary carcinoma also, you will not see myoepithelial cells within the papillae and also at the periphery. So the next thing in invasion is papillary carcinoma, which shows well-formed papillae. So once you see well-formed papillae, it can be invasive papillary carcinoma. In this also, you will not see myoepithelial cells within the papillae and also at the periphery. So this is the flow chart, and to summarize this flow chart, first thing you should look for is the architecture, whether it is forming papillae or not, to identify whether it is a papillary neoplasm. The next step is you should look for invasion, next capsule, next is myoepithelial cells, whether they are distributed within the papillae and at the periphery. Coming to case 1, a 35-year-old female present with swelling in the subareolar region and bloody nipple discharge. What is the papillary breast lesion shown in the image? This is the question. And these are all the options: solid papillary carcinoma, papillary DCIS, intraductal papilloma, and encapsulated papillary carcinoma. Now we'll exclude one by one. So first, what did I tell you? You should confirm whether it is papillary neoplasm or not. So are you seeing papillae here? Yes. So this is a large dilated duct. Okay. So this is large dilated duct. Here is a small duct. This is small duct, and this is large dilated duct, which is filled with the papillary proliferation. So you are able to see arborizing proliferation of fibrovascular coats lined by epithelial cells arising within a single duct. Okay. So next thing, what did I tell you? You should look for one, invasion, next is capsule and myoepithelial cells. First we'll see whether invasion is there or not. Are you able to see invasion here? No. So it is confined to the duct. Okay. The lesion, entire thing is confined within a duct. Okay. So it has not extended beyond the duct. So there is no stromal invasion. That is first thing. Next is capsule. Whether there is any capsule? No. There is no capsule. Next is myoepithelial cells. In the myoepithelial cells, so you should look for the myoepithelial cells present in the center and also at the periphery. So in the arrows as shown here, so these arrows are indicating the myoepithelial cells in the papillae and myoepithelial cells in the periphery. So there are these flat cells or nothing but the myoepithelial cells. Flat cells here, here, okay, here. All these are nothing but the myoepithelial cells. So myoepithelial cells are preserved in the periphery as well as in the center. So what will be your diagnosis? It is a case of intraductal papilloma. Why is it not solid papillary carcinoma? Solid papillary carcinoma will have solid sheets. Here papillary architecture is seen. And solid papillary carcinoma is invasive. In situ can also be there, but when it is not given as DCIS, it means that it is invasive solid papillary carcinoma. And why is it not papillary DCIS? In papillary DCIS, the myoepithelial proliferation will not be present in the center. They will be present only in the periphery. And our diagnosis is intraductal papilloma. And why is it not encapsulated papillary carcinoma? There is no capsule. Okay. So now final diagnosis is ductal papilloma central type. In the previous slide which we have seen, there was papillary proliferation only in a single duct. That's why it is central type. But now here you are able to see multiple ducts are involved. Okay, so this is one duct, this is another duct, this is another duct, this one is another duct. So almost 5 ducts are involved by the proliferation, papillary proliferation. So there is multiple ductal involvement. So it is known as peripheral papilloma. So intraductal papilloma, peripheral type. So you can see multiple peripheral papillomas arising in terminal duct lobular units, and it is located peripherally. Diagnosis will be duct papilloma peripheral type, but in our case scenario it is duct papilloma central type. So here you can see the illustration showing arborizing proliferation of fibrovascular coats lined by epithelial cells and myoepithelial cells. Okay, so it is large dilated duct, and this is arborizing proliferation of papillae lined by epithelial cells and myoepithelial cells. This is a diagram showing myoepithelial cells preserved in the center of the lesion in between the papillae and also at the periphery. The entire papillary neoplasms will be revolving around the myoepithelial cells. That's why I am stressing this many times about the myoepithelial cells. So you are able to see retained myoepithelial cells within the papillae and at the periphery of the lesion around the duct. So in this you are able to see myoepithelial cells demonstrated by IHC, that is P63, calponin, SMA. All this can demonstrate the myoepithelial cells present at the periphery of the lesion, okay, around the duct and also in between the papillae. So this is about intraductal papilloma. Intraductal papillomas can be two types, central papilloma and peripheral papilloma. I have shown you the images of both the things. In central papilloma, you will see large lesion involving the central or subareolar ducts. It occurs in middle-aged women, whereas in peripheral papilloma, the terminal duct lobular units are involved and it occurs in younger women. Solitary lesion is seen in central papilloma, whereas multiple lesions are seen in peripheral papilloma. And central papillomas, usually they are very close to the nipple and areola. They present with nipple discharge, whereas peripheral papillomas, they present as palpable mass and nipple discharge is uncommon. Malignancy risk is low in case of central papilloma. That's why simple excision of the affected duct can treat the condition, whereas peripheral papilloma will have higher malignancy risk. It can be associated with atypia or ductal carcinoma in situ. Hence, wider excision or segmental resection is needed in case of peripheral papilloma. Myoepithelial cells can be absent within the papillae in case of intraductal papilloma. In that case, it will not be classical intraductal papilloma. Myoepithelial cells absent within the papillae indicates atypia, but invasion cannot be ruled out. Only when you see definite stromal invasion, only it is invasion. If the papillae, in between the papillae, myoepithelial cells are not seen, it indicates just atypia. So if this thickness of atypia is less than 3 mm, we'll call it as papilloma with ADH, and if it is greater than 3 mm, it is papilloma with DCIS component. This is case 2. A 60-year-old woman presents with a palpable breast lump. Microscopically, the changes are shown. What is your diagnosis? So it can be intraductal papilloma, papillary DCIS, or encapsulated papillary carcinoma, or invasive papillary carcinoma. So what did I tell you? First rule is whether it is a papillary neoplasm or not. Confirm it. Okay. So here you are able to see this is a duct, okay, and here you are able to see papillae within the duct. So there is papillary font. So it is a papillary neoplasm. The next thing is invasion. Okay, so the lesion is confined to the duct, no stromal invasion, ruled out invasion. Next thing is capsule, no capsule. Okay, so myoepithelial cells, they are absent within the papillae here. Okay, but here there are no myoepithelial cells in between the papillae, but at the periphery you are able to see the flat cells indicated by the arrow. So here these are the flat cells here and here. So this indicates that the myoepithelial cell layer is preserved at the periphery. So what will be your diagnosis? First thing is, it is a papillary lesion, neoplasm. So no stromal invasion, so it is not invasive carcinoma. No capsule, so it is not encapsulated papillary carcinoma. And myoepithelial cells are absent within the papillae, so it is not intraductal papilloma. So what is it? It is papillary ductal carcinoma in situ. This is little magnified view showing papillary ductal carcinoma in situ. So there is papillary proliferation lined by the epithelial cell, and it is confined to duct only. And next thing is, there is no capsule. Myoepithelial cells are absent within the papillary fonts, and myoepithelial cells are retained at the periphery. Here you are able to see illustrative image showing papillary ductal carcinoma in situ. Well formed papillae are seen with fibrovascular core. Here you are able to see, I give a fraction of a second for you to imagine what is this. It is papillary carcinoma in situ. So here in the center there are no myoepithelial cells, only at the periphery. So here there will be myoepithelial cells. So absent myoepithelial cells in the center with preserved myoepithelial cells in the periphery, it indicates papillary carcinoma in situ. Okay, so if both are preserved, it is intraductal papilloma. So here you are able to see the same thing. In the center they are lost myoepithelial cells, and in the periphery they are preserved. Coming to case 3, a 68-year-old woman presents with a painless, slowly enlarging right breast mass since 4 years with no axillary lymphadenopathy, occasional bloody nipple discharge. Imaging, well circumscribed retroareolar lesion on mammogram and ultrasound. Biopsy reveals papillary neoplasm with low-grade cytology. What is the most likely diagnosis? Coming to the history, it is elderly women, slow-growing mass, no axillary lymphadenopathy, giving a clue that malignancy can be excluded little, and occasional bloody nipple discharge. In the imaging also, it is a well circumscribed lesion, and in biopsy it is a papillary neoplasm with low grade cytology. So now again the three thumb rule which we have dealt: invasion, capsule and myoepithelial cells. Based on that, we will exclude one by one. So in this microscopy, what you are able to see, first thing is, there are well formed papillae. So it is a papillary neoplasm, confirmed. Then is invasion. So there is no definite stromal invasion. So invasive carcinoma is excluded. Then is capsule. Yes, there is a well defined capsule here. So when you see capsule in papillary neoplasm, it is definitely, what is it? Encapsulated papillary carcinoma and myoepithelial cells. So in all invasive carcinomas and also in encapsulated papillary carcinomas, myoepithelial cells will be absent within the papillae and also at the periphery. So what will be our diagnosis? No stromal invasion, there is a well-defined capsule and no myoepithelial cells within the periphery and also in the papillae. So it is a case of encapsulated papillary carcinoma. Why is it not intraductal papilloma? In intraductal papilloma, myoepithelial cells will be preserved in the center and also at the periphery, and there will not be any capsule. In papillary DCIS, the myoepithelial cells will be present only at the periphery and no capsule. In solid papillary carcinoma, if it is in situ, myoepithelial cells will be present at the periphery and it will be solid architecture. If it is invasive solid papillary carcinoma, the definite stromal invasion will be present and there will not be any capsule. So it is a case of encapsulated papillary carcinoma. This is another case scenario. So based on this image, which lesion can be misdiagnosed as invasive carcinoma due to the absence of peripheral myoepithelial cells but lacks true stromal invasion? So what is the clue given here? There is no myoepithelial cell rimming at the periphery. But there is also no stromal invasion. So there is no stromal invasion means it is non-invasive. It is not invasive carcinoma. Again, in non-invasive carcinomas, there is absent myoepithelial cell remaining at the periphery. In spite of that, there is a well-formed capsule. So it is a case of encapsulated papillary carcinoma. So here you can see there is no definite stromal invasion. Well-formed capsule is there and myoepithelial cells are absent within the papillae and also at the periphery. So there is well-formed capsule, no myoepithelial cells within the center and also at the periphery. The absence of myoepithelial cells within the papillae and periphery, because of which it mimics invasive carcinomas, because solid papillary carcinoma or invasive papillary carcinoma, both of them lacks the myoepithelial cell rimming at the periphery and also in between the papillae. But in contrast to those invasive carcinomas, there is no definite stromal invasion in case of encapsulated carcinoma, and there is a well-defined capsule here which differentiates it from invasive carcinomas. And differentiating it from intraductal papilloma, there is absent myoepithelial cells within the papillae and also at the periphery. This is a case 5. A 70-year-old woman presents with a well-circumscribed breast mass. Histology shows solidness with delicate fibrovascular coats with definite stromal invasion. Based on the images, what will be your diagnosis? The same thing whatever I am telling till now. First thing is see for the architecture, whether it is solid or papillary. So it is a solid. So it is solid neoplasm. Okay. Definite stromal invasion is there or not? There is stromal invasion. So it is an invasive carcinoma. No capsule, okay, and myoepithelial cells are absent within the papillae and also at the periphery. So it is an invasive carcinoma with definite stromal invasion. There is no capsule and the architecture is solid and there is lack of myoepithelial cells within the papillae and also at the periphery. And one more special feature of this solid invasive papillary carcinoma is it shows positivity for neuroendocrine markers like NSE, chromogranin and synaptophysin. So what will be your diagnosis? It is solid invasive papillary carcinoma. Coming to papillary DCIS, why is it not papillary DCIS? There will not be any stromal invasion in papillary DCIS and the myoepithelial cells will be preserved at the periphery. Why is it not encapsulated papillary carcinoma? There is no definite capsule here. Why is it not invasive papillary carcinoma? Based on the architecture. Here you are able to see solid architecture more. And the expression of neuroendocrine markers is the classical feature of solid invasive papillary carcinoma. Even in situ also you will see neuroendocrine markers positivity. So this is solid papillary carcinoma showing solidness with delicate fibrovascular coats. And all solid papillary carcinomas, they often exhibit neuroendocrine differentiation showing positivity for NSE, that is neuron specific kinase, chromogranin and synaptophysin. This is NSE, chromogranin and synaptophysin. And as I told you, all invasive carcinomas will not show any expression of myoepithelial cells, that is P63 expression is absent between the papillae and also at the periphery. Coming to case 6, a 70-year-old woman presents with a well-circumscribed breast mass. Histology shows solidness with delicate fibrovascular cores and neuroendocrine marker positivity is seen. No stromal invasion is seen. What is the most likely diagnosis? In the previous case, there was a solid nature and neuroendocrine marker positivity is there, but there is definite stromal invasion in the previous case. But here there is no definite stromal invasion, and in this case the myoepithelial cell rimming will be present at the periphery. So what will be your diagnosis? It is solid papillary carcinoma in situ, because because of solid nature it is solid, okay, and neuroendocrine marker positivity is seen in solid lesion. And why is it in situ? There is no definite stromal invasion and myoepithelial rimming present at the periphery. It is solid papillary carcinoma in situ, okay. Coming to case 7, A 55-year-old woman has a breast lesion with papillary architecture and confirmed stromal invasion. Which of the following best describes this entity? So it is elderly women with papillary architecture and confirmed stromal invasion. In the question itself, it is stromal invasion is there. So when you see stromal invasion, what are the two possibilities? It is solid papillary or invasive papillary. So here you are able to see well formed papillae. So it will be invasive papillary carcinoma. But according to the thing which we have learned, the three things: invasion present or absent, capsule present or absent, and myoepithelial cells. You should go in that order to make it easier. So there is definite stromal invasion, so it is invasive, and papillary architecture is there, it is invasive papillary carcinoma. Myoepithelial cells are absent within the papillae and also at the periphery. Okay. So this is an image showing myoepithelial distribution in various lesions. In intraductal papilloma, the myoepithelial cells are present within the fonts, in between the papillae and also at the periphery. In case of papillary ductal carcinoma, within the fonts or in between the papillae, the myoepithelial rimming is absent, but it is present in the periphery. It holds good for papillary ductal carcinoma in situ and also solid papillary carcinoma in situ. Coming to encapsulated papillary carcinoma, there will not be any myoepithelial cells in between the papillae and also at the periphery. But the characteristic feature of this is the presence of capsule, which is not present in any other papillary lesion. Solid papillary carcinoma, here also there will not be any myoepithelial cells in between the papillae and also at the periphery. Similarly, in invasive papillary carcinoma also, no myoepithelial cells within the papillae and also at the periphery. This is a summary table showing type of papillae and myoepithelial cell distribution within the fonts and at the periphery, by which we can diagnose whether it is a papilloma or papillary ductal carcinoma in situ or encapsulated papillary carcinoma or solid papillary carcinoma or invasive papillary carcinoma. With this, I conclude my session, and if you think that it is a little bit useful to you, I request you to follow my channel Dr. Shravani's Med Concepts. Please like, share and subscribe. Thank you.